Question 1. During a laparoscopic cholecystectomy, the surgical technologist notices a sudden, significant increase in smoke evacuation from the surgical field despite appropriate electrosurgical settings. The patient's vital signs remain stable. What is the most immediate and critical action the surgical technologist should take, without prompting? A. Prepare a sterile saline lavage for irrigation. B. Notify the circulating nurse to document the event. C. Inspect the integrity of the electrosurgical pencil and connection. D. Increase the flow rate of the insufflation gas. Answer: C. Inspect the integrity of the electrosurgical pencil and connection. This question tests critical thinking and the immediate response required from a surgical technologist during an unexpected intraoperative event. The keyword sudden, significant increase in smoke evacuation strongly suggests a malfunction or compromise in the electrosurgical system, even if the patient's vitals are stable, which is a key clue to focus on equipment. A damaged electrosurgical pencil or its connection can cause excessive arcing and smoke, posing a fire risk and impacting tissue cutting. Checking the equipment first is crucial for patient safety and to resolve the issue directly. For instance, a small crack in the insulation can cause stray current and excess smoke, requiring immediate attention. Always remember to assess equipment functionality first when an unexpected electrical issue arises during surgery. Question 2. A patient scheduled for an anterior cervical discectomy and fusion, ACDF, presents with a history of severe rheumatoid arthritis affecting the cervical spine. What specialized positioning concern is paramount during intubation and positioning for this procedure? A. Ensuring ample space for the iliac crest graft harvest. B. Preventing excessive hyperextension of the neck. C. Maintaining the Trendelenburg position for venous access. D. Patting the ulnar nerves meticulously to prevent compression. Answer: B. Preventing excessive hyperextension of the neck. This question focuses on the specialized patient positioning considerations, particularly for patients with comorbidities like rheumatoid arthritis affecting the cervical spine. The keyword, severe rheumatoid arthritis affecting the cervical spine, is critical, indicating potential joint instability and increased risk of spinal cord injury if the neck is overextended. Hyperextension could exacerbate existing damage or cause new neurological deficits, making it a paramount safety concern. For example, careful manual support of the head and neck by anesthesia personnel and precise head positioning with a specialized donut or pillow are crucial to maintain neutral alignment. Always prioritize protecting vulnerable areas, especially the spine, in patients with pre-existing conditions. Question 3. During an exploratory laparotomy, the surgeon encounters a large, encapsulated mass that is suspected to be malignant. Upon incision, a significant amount of necrotic, malodorous fluid is released into the abdominal cavity. What is the most appropriate immediate action for the surgical technologist to assist in containing contamination? A. Suction the fluid aggressively and immediately hand a biopsy cup to the surgeon. B. Place absorbent laparotomy sponges around the mass to wall off the area. C. Request the circulating nurse to initiate an intraoperative culture collection. D. Prepare a specimen container for the fluid while the surgeon continues dissection. Answer: B. Place absorbent laparotomy sponges around the mass to wall off the area. This question tests the surgical technologist's understanding of immediate contamination control during an unexpected intraoperative event, specifically with potentially infectious or malignant fluid. The keywords necrotic, malodorous fluid is released are crucial clues indicating the high risk of widespread contamination. Wiping or suctioning immediately without prior isolation risks spreading the contaminants further. Placing laparotomy sponges to wall off the area helps contain the fluid to a localized region, preventing broader peritoneal contamination. For example, this technique helps protect healthy tissues from exposure before suctioning can effectively remove the contained fluid. Remember, always prioritize containment over removal when dealing with significant, uncontrolled spills of contaminated material. Question 4. A patient undergoing a thyroidectomy develops signs of a thyroid storm intraoperatively, including hyperthermia, tachycardia, and hypertension. Which medication would the surgical team most likely request the anesthesia provider to administer first to address the crisis? A. Epinephrine. B. Propofol. C. Propranolol. D. Succinylcholine. Answer: C. Propranolol. This question evaluates the surgical technologist's awareness of severe intraoperative complications and their initial pharmacological management, specifically thyroid storm. The keywords thyroid storm, hyperthermia, tachycardia, and hypertension describe a hypermetabolic state caused by excessive thyroid hormones. Propranolol, a beta blocker, is the most appropriate initial treatment because it rapidly reduces the cardiovascular symptoms, tachycardia, hypertension, that are life-threatening. Epinephrine would worsen the tachycardia, propofol is a sedative not a specific treatment, and succinylcholine is a muscle relaxant often contraindicated in hypermetabolic states. Understanding the immediate pharmacological intervention helps you anticipate needs during such a crisis. For example, a non-selective beta blocker like propranolol effectively counters the sympathetic overdrive seen in thyroid storm. Always prioritize medications that directly address the most immediate life-threatening symptoms in a crisis. Question 5. During a total hip arthroplasty, after reaming the acetabulum, the surgeon requests a bone graft. The patient has pre-existing osteoporosis. Which type of bone graft material would likely be preferred to ensure optimal integration and strength for this patient? A. Autogenous cancellous bone graft. B. Allograft cortical bone. C. Xenograft bone matrix. D. Synthetic ceramic bone substitute. Answer: A. Autogenous cancellous bone graft. This question delves into the nuanced choice of bone graft material, particularly in a patient with a compromised bone quality like osteoporosis. The keywords autogenous cancellous bone graft are key because autogenous refers to tissue from the patient themselves, minimizing rejection, and cancellous bone offers excellent osteoinduction and osteoconduction due to its porous structure and viable osteocytes. For a patient with osteoporosis, maximizing the body's natural healing and integration capabilities is crucial, and autogenous cancellous bone provides the best biological environment for new bone formation. For example, harvesting from the patient's iliac crest offers the gold standard for bone grafting due to its osteogenic properties. Remember that autogenous grafts are always preferred when possible, especially in challenging healing environments. Question 6. A patient is undergoing a laparoscopic appendectomy. After the appendix has been ligated and resected, the surgeon asks for a specimen bag. What is the most crucial consideration for the surgical technologist when retrieving and securing the specimen within the abdomen for removal? A. Ensuring the specimen bag's capacity is sufficient for the appendix. B. Confirming the opening of the specimen bag is fully deployed to avoid spillage. C. Using a sterile long instrument to grasp the appendix and place it directly into the bag. D. Irrigating the peritoneal cavity around the appendix before placing it into the bag. Answer: B. Confirming the opening of the specimen bag is fully deployed to avoid spillage. This question focuses on a critical, often overlooked detail in laparoscopic specimen retrieval that directly impacts aseptic technique and contamination control. The keyword "avoid spillage" highlights the primary risk during specimen removal, especially with an inflamed or ruptured appendix. If the bag's opening is not fully deployed and secured, the specimen could inadvertently touch the trocars or abdominal wall, leading to contamination of the surgical site or port site infection. Ensuring the bag is wide open provides a clear target and prevents the appendix from contacting non-sterile surfaces during placement. For example, a small, partially open bag increases the risk of the specimen scraping against the trocar sleeve as it enters. Always prioritize preventing contamination by ensuring all tools and devices are optimally prepared for their intended use. Question 7. During a complex vascular procedure requiring continuous irrigation, the surgical technologist notes that the irrigation fluid level in the reservoir is critically low. The surgeon is actively operating. What is the most appropriate immediate action by the surgical technologist? A. Inform the circulating nurse that more irrigation fluid is needed. B. Quickly grab a new bag of irrigation fluid and spike it into the tubing. C. Hand the surgeon a damp lap sponge and verbally alert them of the low fluid. D. Aseptically prepare to connect a new bag of irrigation, verbally confirming with the surgeon before making the change. Answer: D. Aseptically prepare to connect a new bag of irrigation, verbally confirming with the surgeon before making the change. This question tests the surgical technologist's ability to anticipate, communicate, and maintain sterility during a critical supply change. The keywords "critically low" and "surgeon is actively operating" emphasize the need for urgent yet controlled intervention without disrupting the sterile field or the surgeon's concentration. The surgical technologist should always be prepared, so having a new bag ready is key, but connecting it without warning could startle or distract the surgeon. Verbally alerting the surgeon allows them to pause momentarily or acknowledge the change, ensuring seamless flow and maintaining focus on the delicate task. For example, you might say, "Surgeon, irrigation is low. I'm connecting a new bag now." Always communicate proactively and prepare supplies in advance to prevent interruptions. Question 8. A surgeon requests a specific type of suture for closing the fascia during an abdominal procedure in a patient with a known history of keloid formation. Which suture characteristic would be the least desirable for this patient's facial closure? A. Absorbable monofilament. B. Non-absorbable multifilament. C. Long-term tensile strength. D. Low tissue reactivity. Answer: B. Non-absorbable multifilament. This question challenges the understanding of suture characteristics in specific patient populations, focusing on a patient prone to keloid formation. The keywords "keloid formation" indicate a propensity for excessive scarring, which is often exacerbated by foreign body reaction and prolonged inflammation. Multifilament sutures, by their braided nature, can harbor bacteria and typically elicit a greater tissue reaction and inflammatory response compared to monofilament sutures. Non-absorbable sutures remain in the tissue permanently, potentially prolonging this reaction. While non-absorbable multifilament sutures are strong, the increased tissue reactivity makes them less desirable in patients prone to keloids. For example, a monofilament absorbable suture like PDS2 might be preferred over a braided non-absorbable silk suture for skin closure in such a patient. Always aim for the least reactive material when a patient has a history of problematic scarring. Question 9. In the event of a significant intraoperative hemorrhage during a major abdominal surgery, what is the first priority for the surgical technologist to provide to the surgeon, without being asked? A. Additional suction tubing and an additional suction canister. B. Large vascular clamps and ligating clips. C. Laparotomy sponges and a large basin for fluid collection. D. bone wax and a topical hemostatic agent. Answer C. Laparotomy sponges and a large basin for fluid collection. This question tests the surgical technologist's ability to anticipate needs and prioritize actions during a life-threatening intraoperative complication like hemorrhage. The keyword significant intraoperative hemorrhage dictates an immediate need to control bleeding and maintain visibility. While other options are eventually needed, the absolute first priority is to absorb the blood pooling in the surgical field with laparotomy sponges and to provide a means to manage the volume of collected blood with a large basin. This allows the surgeon to visualize the source of bleeding for definitive control. For example, a gushing bleed requires rapid absorption to even see where to apply clamps. Always remember that visibility is paramount for the surgeon to effectively address the bleeding source. Question 10. A surgical technologist is setting up for a laparoscopic inguinal hernia repair. The surgeon plans to use a tax device to secure the mesh. What is the most critical safety consideration the technologist must ensure regarding the placement and use of the tax? A. The tacks are made of absorbable material to prevent long-term foreign body reaction. B. The tacks are applied only after complete reduction of the hernia sac. C. The tacks are not applied in close proximity to major vessels or nerves. D. The tax device is loaded with the maximum number of tacks to avoid reloading. Answer C. The tacks are not applied in close proximity to major vessels or nerves. This question addresses a critical safety aspect of using mesh fixation devices in laparoscopic hernia repair. The keywords tax device and safety consideration highlight the potential for iatrogenic injury. The most critical safety concern is preventing damage to underlying structures, specifically major vessels and nerves, which can lead to severe complications like hemorrhage or chronic pain. While other options are good practices, avoiding injury to vital structures is paramount. For example, tacking too close to the femoral vessels or nerves in the groin area could cause permanent damage. Always prioritize protecting critical anatomical structures when using any device that penetrates tissue. Question 11. What is the primary reason for performing a surgical skin prep using a broad-spectrum antimicrobial agent immediately prior to incision? A. To completely sterilize the skin surface. B. To remove all transient and resident microorganisms. C. To reduce the microbial count on the skin to an irreducible minimum. D. To create a sterile barrier on the skin that prevents bacterial migration. Answer C. To reduce the microbial count on the skin to an irreducible minimum. This question probes the fundamental understanding of the goal of surgical skin preparation. The keyword primary reason emphasizes the most important objective. While sterilization is the goal for instruments, the skin cannot be truly sterilized because microorganisms reside in deeper layers. The prep's purpose is to significantly decrease the number of microorganisms, both transient, surface, and resident, deeper skin, to the lowest possible level, thereby minimizing the risk of surgical site infection, SSI. For example, even after a thorough prep, some bacteria will remain, but their numbers are too low to cause an infection under normal circumstances. Always remember that skin prep aims for the lowest possible microbial count, not absolute sterility. Question 12. A patient with a severe penicillin allergy is scheduled for a surgical procedure requiring antibiotic prophylaxis. What would be the most appropriate alternative antibiotic class the surgical technologist should anticipate being administered? A. Cephalosporins. B. Fluoroquinolones. C. Macrolides or vancomycin. D. Aminoglycosides. Answer C. Macrolides or vancomycin. This question tests knowledge of antibiotic classifications and the critical importance of managing patient allergies, particularly penicillin. The keyword severe penicillin allergy is the crucial clue. Cephalosporins, like Ancef/cefazolin, have a cross-reactivity risk with penicillin due to similar chemical structures, making them generally inappropriate for severe penicillin allergies. Macrolides, e.g., azithromycin, erythromycin, or vancomycin are typically the preferred alternatives as they belong to different antibiotic classes and have no cross-reactivity risk with penicillin. For example, a patient with a penicillin allergy might receive clindamycin or vancomycin for prophylaxis instead of a cephalosporin. Always be aware of potential cross-reactivities when dealing with drug allergies. Question 13. During a craniotomy for tumor resection, the surgeon notices significant brain swelling. The anesthesiologist initiates hyperventilation and administers mannitol. What is the surgical technologist's primary role in preparing for potential additional intervention directly related to increased intracranial pressure, ICP? A. Preparing a sterile shunt kit for immediate cerebrospinal fluid drainage. B. Ensuring the operating room is kept cool to aid in brain temperature regulation. C. Having burr-hole instruments and a ventricular catheter ready for placement. D. Preparing a cranioplasty tray for skull defect closure. Answer: C. Having burr-hole instruments and a ventricular catheter ready for placement. This question requires anticipation of interventions for a specific, severe intraoperative complication, increased intracranial pressure, ICP, during neurosurgery. The keywords brain swelling, hyperventilation, and mannitol indicate that conservative measures are already in progress to reduce ICP. If these are insufficient, the next direct surgical intervention to relieve ICP is usually placing a ventricular catheter through a burr hole to drain cerebrospinal fluid. Preparing these instruments ensures the team is ready for this critical, time-sensitive procedure. For example, a surgeon might decide to place an external ventricular drain, EVD, to monitor and drain CSF if swelling persists. Always anticipate the next logical surgical step when conservative measures are failing for a critical condition. Question 14. What is the most critical step in the reprocessing of flexible endoscopes after use, specifically related to preventing transmission of infectious agents? A. Thorough manual cleaning and removal of all visible debris immediately after use. B. Soaking the endoscope in a high-level disinfectant solution for a minimum of 20 minutes. C. Performing a leak test to check for integrity of the scope's exterior. D. Autoclaving the endoscope after high-level disinfection. Answer: A. Thorough manual cleaning and removal of all visible debris immediately after use. This question emphasizes the crucial, foundational step in flexible endoscope reprocessing that directly impacts infection control. The keywords most critical step and preventing transmission of infectious agents point to the absolute necessity of initial cleaning. Manual cleaning, including brushing lumens and wiping surfaces at the point of use, physically removes bioburden, organic material, blood, tissue, which, if left on, can protect microorganisms from disinfectants and lead to failed reprocessing. High-level disinfection is effective only on meticulously clean instruments. For example, if blood is left in a channel, the disinfectant cannot penetrate it, allowing pathogens to survive. Always remember that effective cleaning is the cornerstone of all sterilization and disinfection processes. Question 15. During a total knee arthroplasty, the surgeon is preparing to cement the prosthetic components. What is the most important safety precaution for the surgical technologist to implement regarding the polymethyl methacrylate, PMMA, bone cement? A. Ensure the cement is mixed slowly to prevent air bubbles. B. Have a dedicated suction tip ready to capture cement fumes. C. Verify the cement expiration date before mixing. D. Limit exposure to cement fumes, especially for pregnant personnel. Answer: D. Limit exposure to cement fumes, especially for pregnant personnel. This question focuses on specific safety considerations related to a common surgical material, bone cement. The keywords most important safety precaution and polymethyl methacrylate, PMMA, bone cement highlight the known hazards of its fumes. PMMA fumes contain methyl methacrylate, which is a potent irritant and can be a teratogen, making exposure particularly dangerous for pregnant individuals and generally harmful to all personnel. While other options are good practices, limiting fume exposure protects the health of the entire surgical team. For example, using a scavenging system and ensuring good room ventilation are critical measures. Always prioritize the health and safety of the surgical team, especially regarding known hazardous substances. Question 16. A surgeon is performing a laparoscopic colectomy and requires precise tissue manipulation and dissection. Which type of grasping instrument would be most appropriate for securely holding delicate bowel tissue without causing significant trauma? A. Babcock forceps. B. Allis clamps. C. Coker clamps. D. Peon forceps. Answer: A. Babcock forceps. This question tests the surgical technologist's specific knowledge of laparoscopic instrumentation and its appropriate application to delicate tissues. The keywords securely holding delicate bowel tissue without causing significant trauma are critical. Babcock forceps are specifically designed with a fenestrated, atraumatic jaw that spreads pressure evenly over a larger surface area, minimizing damage to fragile tissues like bowel. Allis clamps and Coker clamps have teeth that would be too traumatic, and Peon forceps are typically used for grasping heavier tissues or for clamping vessels. For example, the Babcock's rounded, non-crushing jaws are ideal for safely retracting the appendix or bowel. Always select instruments that match the tissue's delicacy and the desired level of trauma prevention. Question 17. Which of the following conditions would contraindicate the use of a tourniquet during an extremity surgical procedure? A. Patient with a history of deep vein thrombosis, DVT. B. Patient undergoing arthroscopic shoulder repair. C. Patient with a body mass index, BMI, of 35. D. Procedure anticipated to last longer than 90 minutes. Answer: A. Patient with a history of deep vein thrombosis, DVT. This question assesses understanding of contraindications for tourniquet use, a critical patient safety aspect in extremity surgery. The keyword contraindicate and deep vein thrombosis, DVT, are crucial. A history of DVT indicates an increased risk of thrombus formation or embolization, which can be exacerbated by the venous stasis and potential endothelial damage caused by a tourniquet. While high BMI or longer procedure times require careful monitoring, a DVT history presents a direct and serious contraindication due to the risk of dislodging a clot or forming a new one. For example, a patient with a previous DVT may require alternative methods for exsanguination or hemostasis. Always recognize that patient-specific conditions, especially vascular ones, can significantly impact intraoperative choices. Question 18. During a posterior spinal fusion, after pedicle screw placement, the surgeon requests a neurological assessment tool to confirm proper nerve root decompression. What common intraoperative monitoring technique would the surgical technologist anticipate facilitating? A. Electroencephalography, EEG. B. Somatosensory evoked potentials, SEPs. C. Bispectral index, BIS, monitoring. D. Arterial blood gas, ABG, analysis. Answer B. Somatosensory evoked potentials, SEPs. This question targets knowledge of intraoperative neurophysiological monitoring, specifically in spinal surgery. The keywords posterior spinal fusion, pedicle screw placement, and nerve root decompression clearly indicate a need to monitor spinal cord and nerve function. Somatosensory evoked potentials, SEPs, are used to monitor the integrity of the sensory pathways of the spinal cord by stimulating a peripheral nerve and recording responses from the brain. This helps detect nerve compromise that could result from screw misplacement or insufficient decompression. EEG monitors brain activity, BIS monitors depth of anesthesia, and ABG analyzes blood gases. For example, a sudden decrease in SSEP amplitude might indicate nerve impingement, prompting the surgeon to re-evaluate screw position. Always connect specific surgical procedures with the appropriate neurophysiological monitoring techniques. Question 19. A surgical technologist is setting up for a transurethral resection of the prostate, TURP. What unique safety consideration must be prepared for due to the nature of this procedure? A. Availability of a chest tube insertion tray due to potential pneumothorax. B. Ensuring the patient's legs are well padded in the high lithotomy position. C. Preparing for potential TURP syndrome due to fluid absorption. D. Having an arterial line set up ready for continuous blood pressure monitoring. Answer C. Preparing for potential TURP syndrome due to fluid absorption. This question focuses on a specific and serious complication unique to TURP procedures. The keyword TURP immediately signals the risk of TURP syndrome, which results from the absorption of hypotonic irrigation fluid through venous sinuses opened during prostate resection. This can lead to hyponatremia, fluid overload, and cardiovascular/neurological symptoms. While patient positioning, B, is always important, and arterial lines, D, are common in many cases, TURP syndrome is the distinct, life-threatening complication specific to this procedure that the technologist must anticipate and prepare for, e.g., by ensuring appropriate irrigation fluid is used, and monitoring fluid levels. For example, if non-electrolytic irrigant like glycine is absorbed, it can cause hyponatremia. Always be aware of procedure-specific complications and their associated preparations. Question 20. When preparing instruments for sterilization, which action is most crucial for preventing the formation of biofilm within lumens and crevices? A. Placing instruments in a sonic cleaner before manual washing. B. Immersing instruments in an enzymatic cleaner solution immediately after use. C. Thoroughly drying all instruments before packaging. D. Wrapping instruments tightly in a sterile drape for transport. Answer B. Immersing instruments in an enzymatic cleaner solution immediately after use. This question addresses a critical aspect of instrument reprocessing that impacts infection control, preventing biofilm formation. The keyword biofilm highlights the tenacious protective layer bacteria can form, making them resistant to sterilization. Immersing instruments in an enzymatic cleaner at the point of use immediately after surgery helps to break down organic debris, blood, tissue, before it can dry and harden, which is crucial for preventing biofilm from developing. Delaying this step allows organic matter to create a matrix where biofilm can flourish, hindering subsequent cleaning and sterilization. For example, dried blood in a lumen creates a perfect environment for bacterial colonization that even autoclaving might not fully penetrate. Always remember that immediate, effective cleaning is the first defense against biofilm. Question 21. A patient develops a severe intraoperative allergic reaction with bronchospasm and hypotension. The surgical technologist must anticipate preparing what immediate pharmacological agent for the anesthesia provider? A. Atropine. B. Succinylcholine. C. Epinephrine. D. Lidocaine. Answer: C. Epinephrine. This question tests the surgical technologist's understanding of emergency pharmacological interventions, specifically for a severe allergic reaction, anaphylaxis, during surgery. The keywords severe intraoperative allergic reaction, bronchospasm, and hypotension describe the classic signs of anaphylactic shock. Epinephrine is the immediate drug of choice because it acts as a vasoconstrictor to treat hypotension and a bronchodilator to treat bronchospasm, directly counteracting the life-threatening symptoms of anaphylaxis. Atropine treats bradycardia, succinylcholine is a muscle relaxant, and lidocaine is an anesthetic. For example, the rapid administration of epinephrine can be life-saving by reversing the physiological collapse. Always anticipate epinephrine as the primary treatment for severe anaphylaxis. Question 22. In a situation where a surgical count is incorrect during a critical phase of wound closure, e.g., peritoneal closure, and the missing item cannot be located after thorough searching, what is the next critical step the surgical technologist should initiate? A. Repeat the entire count with a new set of personnel. B. Inform the surgeon immediately and prepare for an intraoperative X-ray. C. Document the discrepancy in the patient's chart and continue with closure. D. Search waste receptacles and soiled linen again more thoroughly. Answer: B. Inform the surgeon immediately and prepare for an intraoperative X-ray. This question assesses the critical sequence of actions when a surgical count discrepancy cannot be resolved, emphasizing patient safety. The keyword missing item cannot be located after thorough searching signifies that all initial efforts have failed. The absolute next critical step is to inform the surgeon immediately, as they are responsible for patient safety and must decide on further action, such as an intraoperative X-ray to locate the missing item. Continuing with closure, C, is never acceptable with a missing item, and while repeating the count, A, or researching, D, are part of the initial thorough searching, they are not the next critical step after that search fails. For example, a missing sponge could cause an abscess or other serious post-op complication. Always escalate count discrepancies to the surgeon and prepare for imaging if the item remains missing. Question 23. A patient is undergoing an abdominal aortic aneurysm, AAA, repair. After the aorta is cross-clamped, the surgical technologist must be vigilant for potential changes in what physiological parameter due to the sudden increase in afterload? A. Heart rate. B. Central venous pressure, CVP. C. Blood glucose levels. D. Urine output. Answer: B. Central venous pressure, CVP. This question delves into advanced physiological responses during specific vascular procedures. The keywords abdominal aortic aneurysm, AAA, repair and aorta is cross-clamped indicate a significant alteration in systemic circulation. When the aorta is cross-clamped, there is a sudden and dramatic increase in systemic vascular resistance, afterload E, proximal to the clamp. This increased resistance causes a rapid rise in central venous pressure, CVP, as blood backs up into the heart's right side, often requiring immediate anesthetic intervention. While heart rate, blood glucose, and urine output might also be affected, the CVP change is a direct and immediate consequence of the clamping. For example, a sudden rise in CVP signals increased cardiac strain and requires immediate management by the anesthesia provider. Always anticipate the immediate physiological consequences of major surgical interventions. Question 24. What is the primary purpose of the timeout procedure performed immediately prior to surgical incision? A. To allow the surgical team to take a brief break before starting. B. To confirm patient identity, surgical site, and procedure with the entire team. C. To review the patient's complete medical history and allergies one final time. D. To confirm that all necessary instruments and equipment are available. Answer B. To confirm patient identity, surgical site, and procedure with the entire team. This question tests the foundational understanding of one of the most critical patient safety protocols in the operating room. The keywords primary purpose and timeout directly refer to this universal protocol's core function. The timeout is a mandatory pause where the entire surgical team verbally confirms the correct patient, the correct surgical site, marked and visible, and the correct procedure, preventing wrong site, wrong procedure, and wrong patient errors. While other checks, C, D, are important, they are either part of earlier pre-op checks or secondary to the core safety confirmation. For example, if a patient is scheduled for a right knee scope but the consent says left, the timeout would catch this discrepancy. Always remember the timeout is the ultimate safeguard against fundamental surgical errors. Question 25. During a surgical procedure on a patient known to be positive for Creutzfeldt-Jakob disease, CD, what additional precaution is paramount for instrument reprocessing compared to standard sterilization protocols? A. Instruments must be flash sterilized between uses in the same case. B. Instruments must be disposed of as biohazard waste after the procedure. C. Instruments require extended sterilization cycles or specific prion deactivating protocols. D. Instruments should be cleaned with a germicidal detergent and then air-dried. Answer C. Instruments require extended sterilization cycles or specific prion deactivating protocols. This question tests advanced knowledge of infection control and the specific challenges posed by unique pathogens like prion. The keyword Creutzfeldt-Jakob disease, CD, immediately signifies the presence of prion, which are highly resistant to conventional sterilization methods. Standard autoclaving and chemical disinfectants are insufficient for prion. Therefore, instruments used on CJD-positive patients require specialized, extended sterilization cycles, e.g., increased temperature, pressure, and duration, or specific chemical solutions designed to deactivate prion, often leading to disposal of single-use items. For example, a common protocol involves extended steam sterilization at higher temperatures, sometimes followed by chemical immersion. Always understand that prion diseases necessitate unique, stringent reprocessing protocols beyond routine measures.